Thank you, Shripriya. Today, I would like to welcome our faculty, Dr. Mary Abraham. She is a neuroanesthesiologist and pain and palliative care physician. Her present position is she's a senior consultant at Max Hospital, Panchsheel, New Delhi, Max Institute of Cancer Care, Lajpat Nagar, the Pain Clinic, the private clinic, B1 sector, Vasantpur, New Delhi. Her former positions were she was professor at GB Pant Hospital, New Delhi, director of anesthesia, Fortis Hospital, Noida, and she was awarded Lifetime Achievement Award by Delhi Neurological Association for contribution to neurosciences in Delhi in Feb 2017. Dr. Mary Abraham, I think I had attended one of your session and when we were doing a fellowship in palliative care, and she's an excellent speaker. It's really heartwarming to see you again, to listen to you again, and to go back to the basics. I welcome you, Dr. Mary Abraham. Over to you.
Thank you, Sheila. And it's indeed a pleasure to be here again. I think after a gap of few months, I think I've heard.
Yeah.
But it's always a pleasure to speak to the audience, particularly those who are interested in palliative care, because I believe that, whatever field you are as a doctor, knowing the basics of palliative care is so important, because you don't know when someone will benefit from it.
Right.
And there are people, the cancer is increasing day by day. 1 in 5 patients are affected with cancer. We know so many people. And if you can lend a helping hand to them, it will make a world of difference to them. Because believe me, even today, even in cities like Delhi, they don't know what to do when a person is suffering from terminal cancer. Even just 2 days ago, there's a young lady who is in stage 4 terminal cancer, and her family, they're clueless as to what to do. They don't know whether they have to take her to a hospital, and particularly she's terminal. She doesn't have more than 2-3 weeks to live. At that stage, then, if you can give that kind of care at home, it will be a boon not only for the patients, but also to their caregivers. It will be really heartening. So it is very important for all of us to know something about palliative care. I'm so glad that these sessions are now reaching to the nook and corner of our country and even abroad, so that more and more people are acquainted to the basics of palliative care, so that they can play an important role in society, particularly for suffering. With these few words, I would like to start my presentation. Just give me a minute. I have to open it 1 second.
I would like to add, ma'am, that Pallium India is doing an excellent job in spreading this awareness.
Exactly.
And not only cancer, and even chronic diseases, if you see, more than cancer, I feel, hypertension, diabetes, CKD, asthma, COPD, ILD, even these people need palliative care, actually. It's not only cancer.
Yes. It can be anybody with stroke, anybody with, multiple sclerosis. It could be anybody with TB spine. Recently I had a patient who had TB spine, not able to move from the home, but having so much of pain. You can treat them also at home.
You're right.
So it makes a lot of. So with these words, I'd like to start with my presentation. So this is a broad outline of my presentation. I'll be talking about the basics of the WHO ladder, the step 1 and 2 drugs of the WHO ladder, and the adjuvant drugs that are given, and some drugs for neuropathic pain. So what is a WHO analgesic ladder? This was based on the recommendations of a group of international experts as part of a vast healthcare program called WHO Cancer Pain and Care Program. So they met and they devised this ladder way back in 1986 to manage cancer pain. And subsequently, over the last 30 odd years, it has been translated into 22 languages, and it has served as a catalyst for treating cancer pain worldwide. And even today, our basics of our management, pain management, is still based on the WHO analgesic ladder. It's relevant even in the 21st century. So what is it? It is a stepwise approach to treat cancer pain depending on its severity. Now, prior to this, that is prior to 80s, people were dying of unnecessary pain because of two reasons. One was there was a lot of drug regulation associated with prescribing and giving opioids. There was a stigma associated. So people felt that, if I take opioids, or if the caregiver hesitant to give it to loved one, thinking that, they will become addicts. Also, it was not easy to procure them because of all the strict rules and the long red tapeism associated with procuring opioids. But when the WHO ladder endorsed it, it actually legitimized the use of opioids because it is coming from the WHO, and they started spreading awareness about this ladder to all parts of the world. Now, I'll start with a case scenario to understand how we can apply it in our day-to-day practice. A 35-year-old father of two kids had squamous cell carcinoma right upper lobe. He had a deep-seated gnawing pain in the right shoulder with burning and tingling sensation in the right arm. He was unable to sleep. The pain score was NRS 4 during the day and 6 at night. So how do we handle this patient? I will talk about it again at the end of my presentation. Now, first of all, when a patient comes with pain, what we need to do is a comprehensive assessment of pain. I think this has been dealt with in your earlier talk about the introduction to pain and the assessment of pain. So just remember there's a mnemonics PQRSTU, in which you follow this, you'll be able to decide the nature of pain and assess the pain. But in the WHO ladder, we are looking more at the severity of, because the ladder is applied based on the intensity of pain. So this S is what you're worried about. You have to gauge the severity of pain. And then also you need to know whether this pain is a nociceptive pain or a neuropathic pain or a combination of them. Because based on that, you may have to add an adjuvant, or you may have to, combine various drugs. So it is important to assess whether it's a nociceptive and neuropathic. Now, what is this ladder? Now, it is a 3-step ladder in which the step 1 is for mild pain, where the NRS is about less than 4, 3 to 4, you can see. So in this, where the pain is only that much, then you can start off with a non-opioid analgesic with or without adjuvant drug, depending upon whether there is any other kind of symptoms. Now, if the patient is not responding to this, then you can go up to step 2, which is you have to add a weak opioid to this. So you give a weak opioid with or without non-opioid, with or without adjuvant. And if the patient does not respond, this is usually for moderate pain, where the NRS score is between 5 to 7. But if it is more than 7, or if the pain is very severe, then you may have to substitute a weak opioid with a strong opioid. So you have to give a strong opioid with a non-opioid, with or without an adjuvant. Okay. Now, using this step ladder approach, nearly 71 to 76 patients of cancer can get satisfactory relief. So it is a very useful tool in the hands of the palliative care doctor. Now, what are the salient features of the ladder? Just remember 3 things: by mouth, by ladder, by cloth. Okay, the first 3. So by mouth is all these WHO analgesic ladder drugs are given orally, even for the strong opioids. And that's a huge advantage because you can give these drugs even at home. Very good for domiciliary care. It can be given by the domiciliary nurse. It can be given by the attendant of the patient. You have to just explain how it has to be given. So oral administration is very much feasible even for strong opioids like morphine. The second is by the ladder. Usually, it's not always true, but usually we start with step one, and according to the severity of pain, we move up the ladder. But if it is very severe pain, you can start with step three. The third is by the clock. Now, that means you give it depending upon the duration of action of that drug. Now, supposing you're giving morphine, we know that immediate release morphine lasts only for 4 hours. So you have to give it every 4 hours. You don't tell that, wait for the pain to come back and then you give it. Because by then, the patient will have pain and then again bringing it down, it's very difficult. So there are peaks and valleys. We don't want that. We want a constant relief of pain for all the 24 hours. So we tell them that depending on the drug, so you have to specify. In morphine, it is every 4 hours. In paracetamol, it's every 6 hours. If it is a selective, non-selective NSAIDs like etoricoxib, it's only once a day. Naproxen, it's twice a day. So you have to tell them. In fact, you can draw a chart and tell them you give it at 6 a.m., 10 a.m., 2 p.m. Like that, you have to explain that it has been given so that the patient is comfortable throughout the 24 hours. The next very important thing is you have to individualize it to the patient. So the right dose is the one that relieves the pain. Now, it can vary between patients depending upon their pain threshold, depending upon the disease itself. It could be very, very advanced stage. So depending on that, one patient may get full relief with 60 milligram morphine. Another patient can get relief with 120 milligram morphine. But so that is not the issue. The issue is the patient should have relief. The dose that produces the relief is the right dose. Okay. And also you have to tell them that supposing in between that time, if the patient has a breakthrough pain, then how do you handle it? What do you give? All that has to be specified to the patient. Then you have to use adjuvants. Now, this can be added at every step of the ladder so that the associated symptoms are also taken care of. Whether it's a neuropathic pain, whether it's a bowel obstruction pain, whether it's a muscle spasm, all this can be taken. And then last but not the least is attention to detail. That means you have to take the patient's age into consideration, the body habitus, the comorbidities, the allergies of the patient, all that has to be factored, what medicines he's already taking. So you have to attend all that and look for the side effects and monitor the patient very carefully. That is attention to. So the advantages of the WHO analgesic ladder are that it is simple, very easy to understand. It's a validated tool. That means it has been found to be effective when it's applied in the proper way. It is cost effective. Most of these drugs are very inexpensive drugs, not very costly drugs. So it is cost effective. Then it can be implemented across the world, even in the remote areas of the world. Okay, like underdeveloped countries, you can easily apply the WHO analgesic ladder. Very well suited for home care, I told you earlier. And it's also applicable for acute and chronic cancer pain as well. Okay. So it can be given even for acute pain like fracture, post-operative pain. Also, you can apply even non-cancer pain like sciatica or any other kind of non-cancer pain you can. Now, this ladder has been modified. The original ladder was unidirectional. You start with the lowest step and then you keep going up. But now they have found that if the patient is very having severe pain, you can omit step 2 and you can directly go up to step 3, or you can add a fourth step, treat crisis of chronic pain that is not responding to even the oral. So this is one of the modifications which came out in 2000. That is for those patients, like 10 to 15% of patients who have intractable pain. So you can give for them other adjuncts like nerve blocks, epidural, patient-controlled analgesia pumps. You can give a neurolytic block. You can give spinal cord stimulators or even intrathecal opioids. So this can be added as either as a fourth step, or sometimes, you can even give nerve block even earlier also if the patient is having a lot. So this is the various kind of interventions that you can do to manage difficult pain not responding to step 3 drug. Now let's talk about step 1 drugs. Like I said, this is used for mild to moderate pain, and the drugs are paracetamol or acetaminophen, and non-steroidal anti-inflammatory drugs can be combined with an adjuvant drug as well. So paracetamol acts centrally. It acts on the central cyclooxygenase system in the brain. And that is how it is using its pain relief. It has no effect on peripheral cyclooxygenase or peripheral COX. And because of that, the side effects are also less. Like NSAIDs acts on the peripheral COX. And that is how it has got various side effects, which I will talk about later. Now, paracetamol has predominantly an antipyretic and analgesic action. It does not have any significant anti-inflammatory action. So this is one of the drawbacks of paracetamol. So what are the doses? You can give it safely at a dose of 12 to 15 mg per kg every 6 hours. You can go up to 3 grams a day. And push comes to shove, you can even go up to 4 grams in a patient without any liver disease or other comorbid, and in a healthy patient. And a single dose should not exceed 1 gram. The normal dose that we give routinely is 650 milligram 6 hours. There are also sustained release paracetamol preparations that are available. It's 1 gram, in which 250 is released immediately and 750 is released over the next 12 hours. So you can even give, these are also available in the market now. You can also give paracetamol as an infusion, 1 gram every 6 hours. Rectal route is feasible when the oral route is not possible, like patients with oral cancers or mouth opening inadequate, or having other problems like they are not able to take orally. It is very good, safe for pediatric use in a dose of 15 milligram per kg every 6 hours. And toxicity occurs only when you give more than 90 milligram per kg per day. So please remember these, and you can go up on your dose provided you stick to these guidelines. So what is the NNT of paracetamol? What is NNT? NNT is called the numbers. So it is the number of patients who receive a drug, analgesic drug, for one to have 50% pain. Now, the lower the NNT, the more efficacious the drug. So the NNT of paracetamol is 5. That means for every 5 patients, one patient will have more than 50%. So it is actually not that efficacious as non-steroidal anti-inflammatory drugs like ibuprofen or diclofenac. They have got lower NNT. Now, what are the advantages and drawbacks of paracetamol? The advantages are very good safety profile, no adverse effect on gastric mucosa, well tolerated by patients with peptic ulcer, no adverse renal effects, no effects on platelet aggregation, tolerated by patients who are sensitive or allergic to aspirin, and does not affect plasma uric acid levels. But the disadvantages are that you have to give it every 6 hours. It has no anti-inflammatory effect. There is some potential of hepatotoxicity when you give doses of more than 3 to 4 grams a day, when there is impaired liver function, when the patient's alcohol consumption is excessive. If the body weight is less than 50, then you have to restrict the dose to 500 mg QID. And remember that even in liver disease, you can give doses of 2 to 3 grams per day. So that way, it has got a lot of advantages. In cancer pain, it is very good. We still use it as a, even when you're giving either whether tramadol you're giving or you're giving opioids, you can always add paracetamol because it actually improves the number to treat. Now coming to the non-steroidal anti-inflammatory drugs. This, I told you, exerts its effect by inhibiting the enzyme peripheral oxygen cyclooxygenase. This is a very important enzyme in the arachidonic acid cascade, which produces tissue and inflammatory prostaglandins. Now, we all know that ultimately the intermediaries of pain and inflammation is prostaglandins. And this acts by decreasing the prostaglandin release by the due to the tissue injury. So what do prostaglandins do? They cause peripheral sensitization and they amplify the pain. And particularly nociceptive pain, when inflammation is present, it is a prostaglandin that is acting, and this inhibits the prostaglandin. If you look to make it a little easy, this diagram is there, in which here you have a tissue injury over here. Okay. And when these are all the inflammatory mediators that are released. So this is the first order neuron. Here it goes, and this is it goes to the spinal cord, and then you have the second order neuron, and then the third order neuron, right? So it is this peripheral nerve endings that are sensitive to the inflammatory substances like histamine, prostaglandins, all are released when tissue injury occurs. And these drugs are acting at this level, the COX inhibitors, by preventing the release of prostaglandin. Again, here you can see the release of all these tissue byproducts because of tissue damage. And it causes a sensitizing soup around the peripheral nerve ending, which is a nociceptor. And this causes amplification of the pain signal. And this COX inhibits this kind of release of the prostaglandin. Now, we must know that cyclooxygenase exists in two forms. One is the COX-1 and one is COX-2. Now, when tissue injury occurs, various phospholipids are released. This causes the release of arachidonic acid. Arachidonic acid is in the presence of the COX-2 inhibitor, COX-2 enzyme, causes a release of prostaglandins. And it is the anti-inflammatory drugs that are acting at this level and preventing the release of prostaglandin. Now, there is another COX that is also present in the body called the COX-1. This is a constitutive enzyme or the housekeeping enzyme. And that has a beneficial effect in the body. And it causes the homeostatic function of the stomach, the kidney, the platelet function. So when you give an anti-inflammatory substance, it is causing inhibition of COX-2, which is good because it causes decreased release of prostaglandins, but it is also inhibiting COX-1. And that is why you have all the side effects because of the inhibition of COX. I hope it's clear. If you have any doubts, you can ask it. So, non-steroidal anti-inflammatory drugs are of two types. One is a non-selective, which is interfering with both COX-1 and COX-2. And then you have the selective COX-2, which is interfering only with COX-2. That means it is not inhibiting COX-1. So all your homeostatic functions are preserved. So these are the non-selective NSAIDs, okay, which are normally used in practice: aspirin, ibuprofen, naproxen, ketoprofen, diclofenac. Diclofenac is also, partly like a COX selective thing, because it has a beneficial effect on the stomach. Okay. And then piroxicam, ketorolac, indomethacin. So these are some of the non-selective COX inhibitors. So I told you that they inhibit both COX-1 and COX-2, and because of inhibition of COX-1, it produces the adverse effects like GI side effects with bleeding, hypersensitivity like angioedema, urticaria, bronchospasm, and adverse renal effects. But when you inhibit the COX-2, which is also happening with non-selective NSAIDs, then it will, the beneficial effects are occurring. Okay. And that is the anti-inflammatory, analgesic, and antipyretic effect. So, non-selective NSAIDs is a double-edged sword. It has got the adverse effects because of inhibition of COX-1, and it has got the beneficial effects because of inhibiting the prostaglandin. Now, non-selective NSAIDs. I told you they are inhibiting both COX-1 and COX-2. The ibuprofen is one of the non-selective NSAIDs. Its NNT is 2, so it is very good as an analgesic and efficacious. So the dose is 400 mg every 6 hours. Then naproxen is another non-selective NSAID. You can give 250 to 500 mg every 12 hours. Its NNT is also fairly good. See, the NNT of these drugs are better than paracetamol. Paracetamol is 5. Okay. So the side effects I already mentioned, renal side effects, especially if dehydration is present. So whenever you're giving any anti-inflammatory drug, please tell the patient that you drink enough water. Because in the presence of dehydration, the chance of renal damage is much. Then the GI effects like bleeding and ulceration of the GIT and hypersensitivity reaction like respiratory, skin, or genital. Now, the selective COX-2 inhibitors, they're inhibiting only COX-2 enzyme, so they're preserving the COX-1 functions. So the examples are etoricoxib, commonly called leucoxia etoshine. You give it 60, 90, or 120 mg dose once a day. The other one is celecoxib, which is Cerebrex. It is come the brand of Cerebrex. You can give 100 or 200 mg twice daily. And like I told you, diclofenac has got a good effect on doesn't have an adverse effect on the GIT. Its NNT is 2. It can be given in a dose of 50 mg every 8 hours, maximum of 150 mg. So are selective COX-2 inhibitors safe as compared to non-selective inhibitors? It is only where the GIT is concerned that it could be relatively safe. But where the renal damage is concerned, it is as harmful as non-selective NSAIDs. Okay. But on the other hand, the selective NSAIDs are known to have prothrombotic effects. So in the presence, it's likely to cause myocardial infarction and stroke. In fact, one of the drugs called rofecoxib was taken off the market because of these adverse thrombotic events. So in such patients who have comorbidities associated with cardiac or cerebral, then ibuprofen and naproxen would be safe and not non-selective, and not the selective drugs. So we can give NSAIDs in alternate routes like topical doses. Topical drugs are available like gels and creams, sprays, and hello, can you hear me, please? Tina?
Yes, ma'am. Yes, ma'am. We can hear you.
Am I audible?
Audible, ma'am.
Hello?
Audible, ma'am. You're audible.
Yeah. Yes, audible.
Am I audible now?
Yes, ma'am. You're audible.
Okay, actually my that Bluetooth had this thing now problem.
Yes.
Sorry about okay, and also transdermal patches are also available, like diclofenac 200 mg patch is available. So you can give it transdermally, you can give it topically also. So if you look at the risk factors for NSAIDs toxicity, those with GI toxicity and those with renal toxicity avoid the non-selective NSAIDs. And those with risk for stroke and MI, we have to avoid the selective NSAIDs and use all these COX-2 drugs could be harmful in such. Now, moving on, we come to the step 2 drugs. Now, step 2 drugs are not controlled drugs unlike step 3 drugs. So they are more easily available, and these are the weak opioids. So they are given for pain of moderate intensity that is not controlled with step 1. So sometimes I said you can even skip the step 2 if necessary. And the drugs that I'll be talking about are tramadol and tapentadol because that's the one that we are using in practice. Now, tramadol is a centrally acting synthetic weak opioid. It has a dual method of action. One is its opioid effects. It is a mu opioid receptor agonist. And because it is a weak opioid, There's less tendency for respiratory depression and less addiction potential. It also has a non-opioid way of action, and that is it blocks the presynaptic uptake of serotonin and norepinephrine, which is important in the descending pathway of pain. Okay. So there are descending inhibitory pathways which are preventing the pain impulses from going up, and for that, serotonin and norepinephrine is important, and this acts by increasing the levels. So it has got the non-opioid way of action also. Now, it is also useful for neuropathic pain because of this effect, the non-opioid effect. So we can, in patients with neuropathic pain, you can give tramadol. Now, it is a pro-drug. Pro-drug means it's converted to active metabolite for its analgesic. And we use very often a combination of tramadol and paracetamol as a step 2. Now, the advantages are high oral bioavailability. If you're giving orally, very good bioavailability. Plasma half-life is 6 hours. So you can give it every 6 hours. And its oral dose is very potent. It's 1/10 as potent as morphine. So if you want to calculate the equianalgesic dose of tramadol versus morphine, you divide the tramadol by 10 and you will know how much morphine needs to be. Like if a patient is taking 400 mg tramadol, divide by 10, that means a patient is getting equivalent of 40 milligram of morphine. The dose is 50 to 100 mg every 4 to 6 hours. Do not exceed 400 mg. Sustained release tablets of tramadol are also available. You can give it twice daily. The side effects, nausea, vomiting, sedation, dry mouth, constipation, dizziness. There is a risk of seizures when you're increasing the dose more than 400 mg, or when you're giving it along with drugs that reduce the seizure threshold, like tricyclic antidepressants and SSRI, and when you're giving it rapidly IV. So always tramadol, when you're giving it, you add it in 100 ml of saline and give it over a period of 20 minutes. I've got about, can I take about 15 minutes more, Sheila?
Yeah, ma'am, you can. Okay, you.
Thank you.
Fine, no problem.
Thank you. So the next weak opioid is tapentadol. This is also supposedly a weak opioid, but opioid binding studies have shown that it's quite a strong opioid. In fact, 75 mg tapentadol per orally is equal to 30 milligram of morphine, whereas 400 mg of tramadol is 40 milligram of morphine. So it is a little more potent than tramadol. Also has a dual method of action, just like tramadol, opioid as well as non-opioid. And it's not a pro-drug, so there are no active metabolites, okay, unlike tramadol. The dose is very similar to tramadol. Sustained release formulations are available. Maximum daily dose is 400 milligrams. And its side effect profile is less. And the risk of seizure is also less. So when you want to combine analgesic drugs, we have to don't use two drugs of the same category. Like you don't combine COX-1 and COX-2. Like, for example, you don't combine brufen with etoricoxib. I've seen it happening. There are people getting NSAIDs as well as they're getting also the selective NSAIDs. There is no need, and it's not a good combination. Then you don't combine a weak opioid with a strong opioid. If you're giving morphine, there's no need to give tramadol. Okay. Then either if a patient is not effective with weak opioid, move on to strong opioid. But don't add that tramadol also. But the combinations that are favorable are paracetamol NSAIDs with morphine, or paracetamol with NSAIDs, or paracetamol with tramadol. So now let us switch gears and move on to neuropathic pain. Now, we know that 40% of cancer patients have got neuropathic pain. Okay. And then there are also other kinds of pain. See, nociceptive is one, then neuropathic, then bone pain, then bowel obstruction pain, pain due to muscle spasm. There may be associated symptoms. So that is why we use adjuvant drugs to treat all these. So what are adjuvant drugs? Adjuvant drugs have got analgesic properties, but their primary indication is not for pain. I'll explain that as we go on. So they are also called co-analgesics because they are co-administered with other analgesics of the WHO lab. Now, this is one classification of adjuvant drugs, multi-purpose adjuvant drugs, and drugs that are used for bone pain, drugs for bowel obstruction, for musculoskeletal pain, and drugs for neuropathy. So multi-purpose drugs can be given for a variety of pains, but there are specific adjuvants that can be given for bone pain and bowel obstruction and neuropathic pain or for muscles. Now, if you look at pain pathway, we know that this is a peripheral nerve ending or the nociceptor. And so nociceptor pain occurs here at this level because of tissue injury. Anything beyond this comes under neuropathic pain. So the peripheral nerves, the central nervous system, all that, if there's a disease or lesion in any of this, it comes as a neuropathic pain. Also, cancer pain can be a combination of the two, both nociceptive and neuropathic. So that is why it's important to assess the kind of pain the patient has. So neuropathic pain, I said, can occur in 40% of patients with cancer. It is because of either direct invasion or compression of the nerve by the disease process itself, or it could be because of the treatment of cancer. Like chemotherapy can damage the peripheral nerves. It's called chemotherapy-induced peripheral neuropathy. Or it could be radiation-induced peripheral neuropathy. Because all that, besides destroying the cancer cells, it can also harm the nerves as well, normal tissues. Then, when there's a surgical excision, there could be injury to the nerve that can lead to neuropathic pain. And sometimes you see it in cancer survivors. Months and years after the patient has been cured, they can still have neuropathic pain, peripheral neuropathy. So we need to know how to treat it. So first line of treatment of neuropathic pain is anticonvulsants. That is why I say that they are adjuvants, because the primary action is for giving for seizures, but it is good for pain as well. So this is a first line treatment. The other first line treatment is antidepressants. I'll talk about that later. So why are anticonvulsants used for neuropathic pain? Because both in epilepsy and pain, there's an increased neuronal hyperexcitability, and these drugs dampen the hyperexcitability. And the drugs that are used are gabapentin, pregabalin, sodium valproate, etc. So how do they act? Now, pregabalin acts by binding to the voltage-gated calcium channels and prevent the calcium entry into the presynaptic neuron. And because of that, there is a decreased release of the excitatory neurotransmitters into the synaptic cleft. That is between the preganglionic and the postganglionic membrane. And because of that, this postsynaptic neuron is not excited. That is how it acts. Preventing entry of calcium, preventing release of the excitatory neurotransmitters, and preventing activation of the postsynaptic neuron. So what are the drugs? The advantages are, it is very good in neuropathic pain, well tolerated by patients, less chance of drug-drug interaction, and the side effects are somnolence, excessive drowsiness, dizziness, ataxia, fatigue, edema, and weight gain. So all this has to be explained to the patient when we are starting on these anticonvulsants. Now, gabapentin is less expensive, but its bioavailability is unpredictable. So you have to start with a small dose and titrate it over a period of time to the proper dose. Whereas pregabalin, you can titrate it more easily, but it is more expensive. Okay? But both drugs are very commonly used for neuropathy. Topical gabapentin is also available, and another drug like topical capsaicin is also available for neuropathy. The other first-line drug for neuropathic pain is antidepressants. Its analgesic action takes up to a week. So when you're starting on antidepressants, tell the patient, don't expect any results for at least a week. So it even occurs earlier than its antidepressant action. Okay. And at a much lower dose. For depression also is given, but at a higher dose. So because of its antidepressant effects, it is very useful in patients with depression, anxiety, and insomnia, which we are very commonly encountering in patients with cancer. So that way it has a double effect also. How does it act? It acts by inhibiting, I told you about the activation of the descending inhibitory pathway of pain by increasing the levels of norepinephrine and serotonin. That is how antidepressants act. So the action is similar to tramadol and tapentadol. So the antidepressants in common use are the tricyclic antidepressants, the selective serotonin receptor inhibitor, the serotonin norepinephrine receptor inhibitor, and now there's another class which is called NASA, and then you have the atypical antipsychotics like quetiapine, risperidone, olanzapine, etc. I'll be talking about the first three because that is what we are commonly using. So these are the tricyclic antidepressants like amitriptyline, nortriptyline, and SSRI include duloxetine, SNRI include duloxetine and venlafaxine, and SSRI include escitalopram, citalopram, paroxetine. Just remember that the SSRI have got less analgesic effects, but more for treating anxiety and depression. So this is how, if you look at the analgesic efficacy, TCA is more potent than SNRI, which is more potent than SSRI. But if you look at the side effect profile, TCA has got more side effects than SNRI and SSRI. So the side effects of TCA, you have CNS effects like somnolence, dizziness, mental clouding. But remember these anticholinergic effects like dry mouth. It can precipitate glaucoma, blurred vision, cardiotoxicity. These are because of its antimuscarinic effects. It can cause urinary retention, constipation, orthostatic hypotension. So please avoid it in these conditions like cardiac problems or prostatic problems or glaucoma. Avoid. SNRI, again, the same thing, somnolence, dizziness, constipation, and the contraindications are be careful in hepatic and renal insufficiency. How do we give? What are the dose administration? When we give amitriptyline, we start at small doses, 10 mg, and then every 3 to 5 days, you can increase it to 10 to 25 mg till you get a stable level. Nortriptyline also same. Duloxetine also, you can start with 30 mg and increase it to 60 mg. Venlafaxine, you can start with 37.5 and increase to 75. Where gabapentin is concerned, you always start with 100 mg doses and then you increase to 300 and then you can keep going up depending on the tolerance of the patient and the how much relief the patient. Pregabalin, you can start with 50 mg also, 50 mg, 75 mg, and then you can go upwards. Sodium valproate, 200 mg HS, and then you can go up to 200 mg every 3 to 5 days, up to 1 gram a day. Just remember, all these drugs, please adjust the doses depending upon the comorbidities of the patient, and if they have renal dysfunction or liver dysfunction, you have to be very careful. It has been shown that duloxetine is useful for pain and function and the quality of life in patients with chemotherapy-induced neuropathy. Those who are receiving duloxetine for the first 5 weeks had lesser pain as compared to patients treated with placebo. So in the 2020 guidelines, they have recommended duloxetine for the initial treatment of painful neuropathy. What are the other drugs in neuropathic pain? We can use ketamine. Ketamine is it's a NMDA antagonist. It acts at this level. So this is also useful for certain types of difficult neuropathic pain. It has got side effects which can be treated with the benzodiazepine or haloperidol, and it can be given in a variety of routes: IV, IM, subcutaneous, oral, sublingually, etc. And its IM bioavailability is very good, 90% at 5 minutes. Now, ketamine is an anesthetic, but in sub-anesthetic doses, in very low doses, it can be an analgesic. So when you're giving oral ketamine, you can start with 10 mg and go up to 25 mg TDS. And if you're giving an infusion, you can start off with 50 milligram and go up to 100 milligram per day. In difficult pain, you can use ketamine as well. as a burst ketamine infusion. Okay, this we will talk about when we are dealing with difficult. Local anesthetics are also useful for difficult neuropathic pain that is not responding to anticonvulsants and antidepressants. But it can have side effects also. So you have to reserve it only for very severe pain. You can give it as an infusion, IV local anesthetic infusion. When you give, calculate the dose of 5 mg per kg, put it in 500 ml of saline, give it over 1 hour, but with good cardiac monitoring. Or you can use topical local anesthetic. 5% lidocaine patches are available in India, and it is very good to treat post-herpetic neuralgia. Other topical drugs I've already mentioned, topical gabapentin, topical capsaicin are also available to treat neuropathy. So if you look at the neuropathic pain ladder, the first line is amitriptyline and the anticonvulsants like pregabalin and gabapentin, duloxetine, which is an SNRI, and lidocaine patch. The second line of treatment are opioids, particularly the weak opioid like tramadol and methadone. And now they're even showing that morphine is also good for neuropathy. And the third line is ketamine, capsaicin patch, mexiletine, baclofen, etc. Now, corticosteroids, now we move away from neuropathic pain and we are talking about multi-purpose adjuvants. Corticosteroid is a multi-purpose adjuvant. Why is it multi-purpose? Because it can be given for a variety of conditions like neuropathic pain, bone pain, headache because of metastasis in the brain, for arthralgia, for obstruction of the bowel, and for spinal metastasis. The drug that we commonly use is dexamethasone. Why? Because it is very, very potent anti-inflammatory effect. And the second is it has got less mineralocorticoid action. So there's less degree of fluid and water retention. And also its half-life is 4.5 hours. So you can, duration of action is 36 to 56 hours. You need to give it only once a day. So that's the advantage of dexamethasone. So I said it's a first-line drug, potent anti-inflammatory action, less mineralocorticoid effects, but give it in the morning because it can tend to cause insomnia. And particularly those with less life expectancy, we can give a trial of steroids like this. And what are the doses? For malignant bowel obstruction, you can go from 6 to 16 milligrams in 24 hours, IV. For brain mets, you can use 4 to 8 or even up to 16. And even it is useful for appetite stimulant. And it has a mood elevation property also. So the patient generally will feel good with that support. The other adjuvant drug is GABA receptor agonist drugs. Now we know that the GABA is an inhibitory neurotransmitter. So these drugs are potentiating the effect of GABA. So we have two kinds of GABA receptors, GABA A. All the benzodiazepines come under GABA A agonist. And out of the benzodiazepines, clonazepam is the one that is good in cancer, particularly because it has some effect on neuropathy. And the GABA B agonist is baclofen. So clonazepam, when you want to give, you can give 0.5 milligrams at night, for particularly good for sleep and good for neuropathic pain, also useful for pain for terminal sedation of the patient. And GABA B is baclofen, particularly useful when there's spasticity and neuropathic pain. And you can start with 10 milligrams and go up to 20 milligrams. In bone pain, you can give, it's very agonizing and needs to be treated. The various drugs are corticosteroids, NSAIDs, then calcitonin, bisphosphonates, and denosumab, which is the one that is most commonly used because it inhibits osteoclast-mediated bone resorption, and palliative radiation. So bisphosphonates is very useful for intractable metastatic bone pain secondary to breast and prostate cancer and multiple myeloma, acts by blocking the osteoclastic activity and decreasing the bone resorption. The one that we commonly use is zoledronic acid, IV in 100 ml of saline over 15 minutes, and you can give it every 3 to 4 weeks for 1 year. Has side effects like pyrexia, renal dysfunction, and osteonephrosis of the jaw, and you need to adjust the dose for patients with renal dysfunction based on the creatinine clearance. So, denosumab. Now, that is a human monoclonal antibody, very useful, but when you compare to bisphosphonates, it's very, very expensive. Can be given subcutaneously, less risk of renal toxicity, and it is superior in preventing the fractures and skeletal related events. Now, palliative radiation can also be given, particularly when it is focal metastasis causing pain. So, this is one of the options for bone metastasis. Now, malignant bone bowel obstruction, particularly for cancer related to the abdomen or pelvic cancers that are infiltrating the bowel, then very good is steroids. I told you the doses in which you can give steroids. Then a somatostatin analog like octreotide is a synthetic hormone that decreases the intraluminal secretions in the bowel and decreases the peristaltic movement. That is also good. You can use anticholinergic drugs like hyoscine butyl bromide or buscopan or glycopyrrolate. Or you can combine all of them and give it, particularly in patients who are having very severe bowel obstruction. Other adjuvant drugs that we give are the skeletal muscle relaxants like thiocolchidoside, tizanidine, chlorzoxazone, neuroleptic agents, particularly when there's delirium, agitation, nausea, vomiting. You can give olanzapine. You can give antibiotics if there's secondary infection. Sedatives also can be given as an adjuvant drug, anxiolytics, laxatives. These are all the various adjuvant drugs that we can give. So if you look at the various sites of action of the various painkillers, muscle relaxant is acting at this level, at the level of the muscle. Okay. And the local anesthetics, topical analgesics, and NSAIDs are acting by preventing the peripheral sensitization at the nociceptor. Now, drugs like anticonvulsants, antidepressants, opioids, NMDA antagonists are all acting at the dorsal horn. And the ones that are inhibiting the descending modulation of pain, they are the alpha-2 agonists, TCAs, SNRIs, and the weak opioids. So they act at different levels of the pain pathway. And that is why you use a combination of drugs sometimes. So we come back to our case scenario. This was a 35, I told you about this patient. How do we treat him? Now, because his pain is mild to moderate, and it's a combination of nociceptive because of the pain at the shoulder with tingling in the arm. So there is a neuropathic element also. It was worse at night, and he was having a lot of emotional, social, and financial concerns. So because of that, we can start with a WHO step 1 drug, like a combination of paracetamol with NSAIDs, because the pain was 4 to 6. But because the pain was worse at night, the night dose could be a long-acting drug, like paracetamol 1000 mg can be given, or sustained release diclofenac. So it tides over the night also. Then, because there's a neuropathic element, you can add an anticonvulsant and antidepressant. And because he has sleep issues, you can add an adjuvant like a sedative, and of course, a psychosocial support because of his financial and social concerns. So that is how we do a total pain management of this. To summarize, WHO analgesic ladder is a sheet anchor for cancer pain management, can also be used for non-cancer pain. The advantages are its simplicity, easy implementation, can be used the world over, and it has more than anything, it has legitimized the use of opioids in cancer and non-cancer. Thank you.
Thank you, Dr. Mary. That was an excellent presentation, very extensive. Participants, I know it would have been very extensive and a lot to retain. But don't worry, go through the slides. It will be available on the IECO platform. And we are there here to answer all your queries. Ma'am, is it okay if we go ahead with the case presentation with a short of
Yeah, please, no problem.
Shreepriya, is it okay if we go with the case presentation first? And
Yes,
then
ma'am,
take the
it is your
questions.
call. It is your call. You are the owner of the program, ma'am.
Yeah. Then we will
We
call
can
Dr.
take the
Om.
questions also during that time.
Yeah, right.
I'm sharing the screen.
Today's case presentation will be by Dr. Osama Omar. He works at Tripoli Central Hospital. You are ready, Dr. Osama?
Okay, ready? Can you hear me?
Yeah, we can hear you, doctor.
Okay, go. Hello, everybody. We have today case presentation for a 65 years old female complaining of chronic lower back pain mechanically with lumbar disc degeneration, with diabetic neuropathy, and osteoarthritis in knee and hip joint. History of this illness, back pain, bowel aching, spreading to the thigh, gets worse with movement and relative with the rest. Next slide, please. Another one. Next slide. Okay. Nerve pain, bowel aching, spreading to the thigh, gets worse with movement and relative with relieving with the rest. Nerve pain, it's neuropathic pain, burning feeling in both feet, more noticeable at night. She has a previous management with acetaminophen, 1 gram 4 times per day, but limited relief to the pain. She avoid non-steroidal anti-inflammatory drug due to gastroesophageal reflux and kidney impairment disease. Functional impact with the sleep disturbance, reduced mobility, and sign of depression. Next one. On examination, vital signs, blood pressure slightly elevated, heart rate, and body mass index was normal. Musculoskeletal tenderness over L4, L5, limited with back movement. Neurological assessment, reduced sensation in the feet with intact deep reflex. Psychiatric depression screening score 3 on 6 with sign of depression. Current medication, the patient she take paracetamol 1 gram 4 times per day, omeprazole for her stomach, 20 milligram once daily, metformin for her diabetics, 1000 milligram twice daily, and lisinopril 10 milligram once daily. She avoid all type of non-steroidal called gastroesophageal reflux and kidney impairment. Next one. On the assessment, there is multi-type of pain. We have mixed pain syndrome, mechanically necessitative, being caused by disc issue and arthritis, worse with movement and pressure. Another type of pain, neuropathic pain or nerve pain due to diabetic neuropathy, burning and tingling in both feet. More severe at night, like it to poor blood sugar control. Contributing factor, there is contributing factor, chronic kidney disease, limited the use of certain pain medication to prevent further kidney damage. Gastroesophageal reflux, prevent the use of oral non-steroidal anti-inflammatory to avoid stomach irritation. Depression, mood changes can worsen pain perception, making pain management more challenging. Another one, please. On investigation, the lab test show poor blood sugar control with hemoglobin A1C at 7.8%, fasting blood glucose at 280 milligram per deciliter. Kidney function is mildly reduced with the glomerular filtration rate at 55 and creatinine slightly high at 1.4 milligram per deciliter. Anemia is presented with hemoglobin at 11.2 gram per deciliter. Vitamin B12 level are bending and thyroid function test is normal. Imaging shows pain disc issue, mild spine narrowing, and joint degeneration in the knee and hip joint. Nerve tests indicate reduced nerve function and increased pain sensitivity in the feet. Next one, please. Management plan. We start by non-drug approach. It's not obviously in the slide. Non-drug approach, physiotherapy, and tense unit electric stimulation to reduce pain, and CBT, cognitive behavioral change or treatment for this patient. And we start by pharmacological, non-opioid analgesic, paracetamol 1 gram 4 times per day. Diclofenac gel can use topically for minimal systemic absorption. For neuropathic, can start by gabapentin, start with 100 milligram at the time, titrated to increase to 300 milligram as we needed. Another drug, duloxetine, 30 milligram once daily, helps with the pain, for neuropathic pain, and for mood, for depression. Another one. For monitoring and safety, should be monitoring for kidney function, check hemofiltration rate monthly to adjust medication. Check another blood sugar, monitoring closely due to potential impact of duloxetine. Gastroesophageal reflux, maintain omeprazole to prevent stomach issue for non-steroidal antidiuretic drugs. Another slide, please. Prognosis, we expect improvement from 30 to 50 reduction in the pain, improve movement and daily activity, regular check-up to adjust treatment plan. Another slide. Discussion point, we avoid opioid, high risk for addiction and not effective for nerve pain, for neuropathic pain. Managing multiple conditions, balancing with the impairment kidney function and gastroesophageal reflux and depression. We should work as a team approach, working with diabetes specialty or endocrinologist, psychotherapist, and physiotherapist and psychologist. For prevention, focus on blood glucose control and monitoring nerve function. And thank you.
Thank you, Dr. Osama. That was a very elaborate and apt presentation.
Thank you.
I wanted to ask you how, can I ask you 1 or 2 questions?
Yes, please.
I just wanted to ask you, with the management of gabapentin, was the pain relief how better for the patient?
I'm not understand.
You had started gabapentin for this patient, right?
Gabapentin, yes.
Yeah. So was the pain relief adequate after starting gabapentin?
When starting by 100 milligram is not effective, and when titrated the dose to 300, it's better result for her.
Okay, so after 300, the patient pain was better?
No, not hospital, not in hospital.
Okay. And did you correct the B12? Because even B12 deficiency may contribute to neuropathic pain. So did you give medicines for B12?
And on the start investigation, B12 is okay, but on the other follow-up, we check B12 if there is insufficiency and give her supplement.
Okay. And why not tramadol or tapentadol? Why that will be effective in neuropathic pain also? The tramadol and the tapentadol, weak opioids. You did not consider starting that?
I'm not to try.
Okay, fine. Thank you, Dr. Osama. Dr. Mary, you have anything to ask? Participants can start asking your questions.
I just wanted to know, what is the pain score of the patient? You mentioned the NRS of the patient. Like, I don't know whether it was mentioned there.
It was
What is
mentioned, I think. Dr. Osama, what was the pain score? The first slide, it was mentioned, I think 6 by. No, ma'am, no, it was not mentioned.
So what was the pain score? Was it mild pain, moderate pain, severe pain?
Dr. Osama, are you there?
You're muted. You're muted.
I'm not mentioned in the slide, but the patient in numerical scale is 6 from 10, moderate to severe.
Moderate.
Mhm.
Then another thing, have you monitored the vitamin D3 levels? That is also very important. Like Sheila was mentioning about B12, we need to monitor the D3 levels as well, because many people have very low D3 levels. So that also needs to be monitored. So if it is
Okay.
low, then you have to give vitamin D3. Okay, please do
Okay.
that also.
Including calcium, ma'am, even calcium would have been beneficial to the.
Yeah, but then if the D3 levels are low, you first need to bring up the D3. Otherwise, the calcium itself will not get absorbed, right?
You're right, you're right. You're right. So,
So
Dr.
that
Osama,
also needs to be done.
and ma'am, discussion, he's asking, he's given the point as high addiction risk with poor efficacy in neuropathic pain for opioids. But I think tramadol will work for.
Yeah, you can give weak opioids in this patient, like tramadol also, because you can't give NSAIDs because of the CKD problem and also because of the GERD, okay, gastroesophageal problem. So tramadol would be a good option in this patient. And like I said, my presentation I mentioned, paracetamol with tramadol, you can give it because it has no side effects on the kidney or on the stomach. Okay, so that is one option you can do for increasing for causing better pain relief. Then another adjuvant you could add in this patient is a muscle relaxant. See, you said there's difficulty in flexion. That means because of the pain, there is a lot of muscle spasms. So you can add a muscle relaxant to this patient. That will also help. And the other thing is, you mentioned about the spine, right? Now, when you have a degenerative spine with the evidence of a disc prolapse and lumbar canal stenosis, the neuropathic pain can also be because of that. It is not nociceptive. The pain that is caused by degenerative spine is a neuropathic. Okay, because it is compression of the nerves. This prolapse is compressing some nerve, or the spinal stenosis is causing compression of the spinal cord. So it's a mixed nociceptive and neuropathic pain. But the diabetic part is a neuropathic pain. That I agree with. Okay.
Ma'am, actually, Dr. Mary, he is from, Dr. Osama is from Libya. So I just wanted to ask whether tramadol will be available over there with the same.
Is it available, tramadol?
It's available, but difficult to reach by the patient, only by highly prescription.
Because in India, we can get tramadol fairly easily, but for strong opioids, we need a special prescription. But tramadol is available at the chemist. If you write a
And
regular
Libya
prescription,
is not available for everyone. Yeah.
So your options are limited now. Only paracetamol. You can't even give any other drug. Yeah.
Can I ask a question, please?
Yes, please, please.
Please. Why we don't think initially to correct the cause of pain? Actually, here the cause is mainly due to disc generation, and we can do for this patient 65 years if he will not do an operative correction, he can do pain management procedures. Also, in osteoarthritis, he can, for example, arthroscopy. By the orthopedician, they can do something for him or for her.
Dr. Khalid, surgery is not always the best option, even for degenerative spine. Only see whenever there's a disc prolapse, it doesn't mean that surgery will make the pain all right. Okay. Now, there has to be a certain indication for
And
surgery.
it is not the first choice. The surgery is not first choice for the patient.
Yeah, no, what I'm trying to say is surgery is indicated if there are certain red flags like urinary incontinence or weakness of the muscles or neurological deficits, because always surgery does not produce pain relief. Always. It can produce, but not always. So it doesn't mean that if there's a disc prolapse, do surgery, it'll become all right. 1 + 1 is not 2. Okay. So we have to be very cautious when we go in for surgery, because I'm a neuroanesthetist and I've done plenty of these operations, and I know that surgery is not the answer always. Conservative treatment is very important, but you have to give a good trial. You can give nerve blocks if necessary. See, if the pain is radiating to one leg, you can give an epidural injection, a transforaminal injection, steroid injection can be given into the spine. Okay.
That's what I mean. Pain management by us.
Yeah, for that, you have to have a radiculopathy. See, it should be going to either the right leg or the left leg. Dr. Osama, where was the radiation of pain? See, because of the disc, was there a radiation of pain to the leg?
Left side, left side.
Okay. So then we have to see the MRI and see whether the left nerve root of L45 is compressed or not. If it is compressed, then you can give a steroid injection. Okay. It's called a transforaminal injection.
Okay, ma'am.
That can produce some relief. But always the answer is not surgery, particularly when there are no neurological deficits.
There's one more
No.
question in the. Can I proceed?
Yeah.
So, how many doses of vitamin B12 will improve the condition? Is it only one shot or complete course should be given?
That depends upon the level of D3 levels. See, the D3 normal levels is...
It's about B12, ma'am. They're asking about B12.
It's a B12.
But you can answer both, actually.
For B12, if it is very low, below 200, then you can give even tablets. You know, there are various tablets which has got 1500 micrograms of methylcobalamin. You can give the tablets regularly. It will bring up the B12. Okay. If you want to correct B3, if the normal levels are some 50 above, but if the level is very low, below 20, you can give an injection of B12, of D3. Injection contains 6 lakh units. Okay, so that will boost up the D3, and then after that, monitor the level, and then you can give 60,000 units weekly doses. You can. Okay. That is available as tablets or sachets. But if it is below 20, I would advise an injection straight away. E3 injections are also available, intramuscular injections.
Dr. Kinjal is asking, nortriptyline would also be helpful in diabetic neuropathic burning pain.
See, if there is burning and tingling, you must add an antidepressant as well. Okay, so either you can give pregabalin with nortriptyline, or you can give gabapentin with nortriptyline. A combination is always very good, particularly when there's tingling and numbness and burning. You can add an antidepressant to the anticonvulsant.
Ma'am, I really have a question for you, if it is okay.
Yeah, please.
Yeah. Ma'am, our experience is many a times when we start gabapentin or pregabalin, especially these two molecules, for initial doses, they gives dizziness more, and patients' acceptance level is very low with these two molecules. So what is your experience? How do you manage drug-induced dizziness in these patients?
See, I start with low doses. Okay. Like if it's gabapentin, I'll start with 100 mg. If it is pregabalin, I can even start with 50 milligrams of it. Okay. And then I will tell them that you please give this drug before 7:38 at night. Okay, don't have it at 10 o'clock, 11 o'clock, the next day you'll feel very drowsy. So you have an early dinner and preferably before 7:30, you have the medicines. Then you feel more fresh in the morning and less sleepy in the morning. And then you have to tell them that you will have some sleepiness, but over the course of few days, your body will get used to it. Then we will increase the dose. If you explain to them, they are very hesitant. They say, no, I feel now zoned out. I feel knocked out in the morning. But tell them they should have it early dinner and early tablet rather than having it very late. And also, this is expected, but it will settle down over a few days. Okay, if you explain to them, they are taking it. I'm giving it regularly to my patients.
We can even start with 25 mg, ma'am. Pregabalin is available even in 25 mg.
And then we
can rapidly escalate after in every 2 days.
Yeah.
Yeah,
If it's available, it's fine. But I usually start with 50 milligram. I don't know about 25 milligram tablet availability.
No, ma'am, we are actually frequently giving these combinations because we are nodal DRTB center. We have so many patients of drug-resistant tuberculosis, and we encountered very frequently linezolid-induced peripheral neuropathy, clofazimine-induced things. So many times what happened, not triptyline acceptance is really good, but when we start pregabalin with methylcobalamin, so initial days patient would complain that already we are taking 3-4 medicines as part of TB treatment, and now you are adding a molecule which is giving us dizziness. So I was just asking for your experience. We are doing
tell them to take it early. Tell them to take it early.
Yes, ma'am. We are doing the same. Just I was asking for your experience. Yes, ma'am.
No. We are giving it and tell them because it can be very disconcerting having burning pain and tingling and all. And I have many patients with diabetic neuropathy who have responded to this kind of thing. And I would say pregabalin is a little better for diabetic neuropathy as compared to GABA. But only thing is a little more expensive.
Ma'am,
So
I have one.
Yeah, tell me.
Ma'am, I have one more question that in tuberculosis, we give pyridoxine, vitamin B6, to prevent neuropathy in moderate dose. We cannot go for high dose because it itself causes seizures. So is there any role of pyridoxine, that is B6, along with B12 in chronic neuropathy pain? Is it like that?
No, we don't give
it. Is it limited? You don't
it's good for tuberculosis, but not for other kind of.
Okay. Right.
But in tuberculosis, you have to give pyridoxine, but I don't give it in my practice. I don't know if anybody else. Sheila, what is your experience?
No, ma'am, we don't give. Only in tuberculosis, not in chronic neuropathic pain. We don't do that, ma'am.
So basically, in this patient, we have to have a very total pain management in this patient. Okay. So we need to tell them for her knee, we have to see the x-rays, how bad is the osteoarthritis. She should do regular exercises. She should do back exercises. And she can, you can add on a muscle relaxant to your treatment. And if tramadol is available, there's nothing like tramadol also because it's good for neuropathic pain. And then, of course, we have to take care of her depression also by counseling, and very important, glycemic control and HbA1c has to also come down because that is also the crux of the treatment for diabetic neuropathy. Have to bring the diabetic control should be better. Maybe you have to add another drug also in addition to metformin.
There's one more question, ma'am. Facet joint injection, is it possible?
Yeah, facet joint is there for patients with lumbar canal stenosis, not for disc prolapse. Okay, but if the patient has a lumbar canal stenosis and facet arthropathy, which is seen in the MRI, definitely you can give facet joint.
And then there's one more question. Will you be considering steroid epidural for PIVD?
Yes, definitely. If it is a radiculopathy on one particular side, we can give a steroid epidural. We do not give lumbar epidural, but we give a transforaminal epidural. Okay, so we target the nerve root. See, for L4-5, it is the L5 route that is affected. So we give it at that point, at L5, where it is exiting from the spine. At the foramen, at that level, we give the transforaminal injection, along with maybe even a caudal epidural injection also. Can give a caudal. But all these injections are fluoroscopic guided injections. Okay, it is given in the operation room under fluoroscopic control. Only then you can target it. Otherwise, it is not safe to give epidural injection without X-ray control.
I had a doubt, ma'am. Do we have pain in interventional specialists? Are they freely, I mean, or we do have a very limited number of interventional pain specialists? Are they very accessible to all the patients, interventional pain specialists, or it's a new field, emerging new field?
No, it's available. You Google it and see pain specialists in Delhi. Most of them are doing interventions.
Okay.
Where are you based, Sheila?
Mumbai, ma'am.
Mumbai, there are plenty of interventions.
In Mumbai. No, I'm talking about a small, not exactly.
I'm telling you, even in Kerala, even in most cities, it is available. But if you go down to the second tier city or third tier city, maybe it's not available. They are not available. But every major city will have interventional pain specialists.
Can I ask a question, please?
Yes.
Sure.
Yes. Is there any rule for the disc generation or ozone injection?
Okay, I have done a lot of ozone injections. Okay, I have a series of 100 ozone injections, and I found it quite beneficial when I did it. But I'm talking of before 2016. Subsequent to that, I think there is a decline in popularity of ozone. But before 2016, I have treated many patients with intradiscal ozone injections. But nowadays, they are not. I think there is no evidence. And see, I can quote many patients who have improved. But unless there's evidence, you can't treat it. So there are no randomized controlled trials. And so ozone's popularity has decreased over the years. But before that, between 2000 and before 2016, it was very popular. We had ozone machines and we used to give intradiscal ozone. But I don't think it is being done. Some centers are giving it, but there is no proof.
Here they are using ozone therapy for bed sores also, ma'am.
Yeah, that is different. I'm talking of intradiscal ozones for disc prolapse.
And RFT, radiofrequency?
Radiofrequency ablation can be done, particularly when there's a facet joint arthropathy. And you can also do dorsal root ganglion ablation. So there are a lot of interventions that are available. The dorsal root can be ablated specifically, or you can even do the medial branch block with RF ablation. Medial branch is the one that's supplying the facet joint. You can do the ablation of that also.
There's a doubt.
But just remember that interventions are, it's not a magic bullet. You do an intervention, don't think that you will get relief. You have to address all the other factors as well. And that is where the problem is. Intervention specialists are so focused on the nerve, they are not looking at the muscles that are involved, which are in spasm, or so many other things. No? So we have to do a holistic management of these patients, along with an intervention if it's required.
And we also have to counsel the patients, because patients may feel once you do intervention, it's like they'll be off pain and it can recur, I mean.
It can recur. That is a problem with interventions. After a few months, they'll again have a recurrence.
Yeah, right.
Steroid also the same thing.
The same thing.
Effect will last for 3 months, then they can have a recurrence. So the main thing is they have to start mobilizing themselves, do regular exercises. They have to go through a regular program, exercise program, so that it doesn't recur up.
Is there, madam, is there a training module on interventional pain management in palliative care medicine? That's one question asked by the audience, the participant.
That you will have to ask Gayatri or Shri Priya.
Yeah. Are anabolic steroids like injection Decadurabolon beneficial for neuropathic pain?
Definitely no.
Anyone else would like to ask? You can unmute yourself. Dr. Osama, would you like to ask anything more about your case? Participants who have any doubts, you can use the
No,
chat
thank
box.
you. No, thank you. It's okay.
By the way, since we have time, I can tell about one technique that I'm using for these patients.
Yeah, ma'am.
It's called dry needling technique. Okay.
Dry needling, yeah, right.
Yeah. So I'm doing a lot of dry needling for my back pain and disc prolapse and facet joint problems, because I find that many of these patients have got associated muscle spasm, and the sciatica along the leg also, all the muscles which are innervated by the L5, which are the hamstrings, and the calves are also involved. So I do a needling technique. Okay. And would you like to see a picture of it? I can show it if you want.
Yeah, ma'am. Sure, ma'am.
Achha, just 1
Yes,
minute.
please.
I'll just show.
Can I take a question, ma'am, till then?
Yeah, you please take a question. I'll just locate my.
Madam, is there a standard treatment for metastatic bony pain like spine tenderness? Like spine tenderness. I mean, what she meant was asking any standard treatment for metastatic bony pain.
It is basically the bisphosphonates and palliative radiation. Okay. I'll just show you 1 second. Yeah, just. Okay, yeah, I've got it here. Can you see it? Can you see my presentation? Can you see it?
No,
Not
ma'am.
yet, ma'am.
Not yet. Okay, 1 minute. I'll just show it. I have to go for start sharing. No?
Yes, ma'am. You just have to share, press the share button. Then lot of windows will come. And
Okay,
then
I
you
got
can.
it. I got it. I got it. Okay, now you can see now.
Yeah, ma'am, we can see them.
Okay, so here I'll just show you. So these are the patients I'm doing dry. See, this is a patient. I'm doing dry needling on a back. These are like acupuncture needles. And this is another patient with a neck pain. I'm doing dry needling. Okay. This is me doing dry needling. I'll just play the video. Maybe you can see it. Can you see it?
Yeah, we can see.
Okay, just see how I'm doing the dry needling for sciatica, low back pain and sciatica. Okay. Here, this is how I'm doing the dry needling. Saw that? This is for axial low back pain, dry needling. This is, I'm dry needling along the sciatica, all the muscles of the thigh and even the knee and the calf. Okay, this is how I do dry. Yeah, I thought I'll just show you. And this is a patient's MRI. You can see how much compression she has here. And this patient, they respond to dry needling a lot because we are not treating the nerve, but we are treating the spasm. And when the spasm is relieved, the nerve is also getting released. So this is very, very common. I use it very commonly.
So dry needling is going to actually relieve the spasm in the muscles.
Yeah, pardon me? What did you say?
How does that dry needling works? It just relieves the spasm. How does it work?
when the needle goes into the muscles that have been shortened, that in this lady, she cannot bend forward. No flexion is not possible. She's having a lot of muscle spasm. So if you needle all her erector spinae and the deep spinal muscles, the spasm gets relieved, the nerve also will get released.
Okay.
Because the needle goes into the muscle, it relaxes the muscle.
Right.
There are a lot of mechanisms of action, which is, I think,
Beyond the scope. Ma'am, what is the type of needle you're using? There's a question.
I'm using acupuncture needles, which are 32 gauge needles, and the length depends upon the muscle that you're treating. If I'm treating the shoulder muscle, I use 40 mm needle. If I'm using the buttock muscles, I have to use 10 centimeter needles, 100 mm needles. So depending on the muscles, various kind of needles are.
There's one more question. What is the duration of treatment for pregabalin?
See, it can be given, I've given pregabalin for months also. But you have to monitor the kidney and renal function. Okay. And it should not be in very high doses. Like in the West, they're giving high doses of 400 and 300 mg. I never go up to that. My maximum is 75 mg twice daily. I don't go beyond that. So that dose, I've given it for months also, but monitoring the kidney and the liver function.
Any role of physiotherapy in pain?
Very important. This is what is called a multimodal therapy. Even when I do dry needling, I tell my patients, please take the physiotherapy also. They will do the stretching and the strengthening and all that. Very, very important. It's all part of a multimodal treatment.
Ma'am, how often do you need to do this dry needling?
Pardon me?
How often do you do the dry needling for the
Now,
patient?
if a patient comes with sudden onset of backache, like I have pain since 2 days, I'm not able to move my back. Even one session is more than enough. I've had patients with one session, they have become all right. But if a patient comes with history of 2 years, 3 years of sciatica, they may need 5 to 10 sessions. I give them twice a week sessions. And I put the needles, keep it for half an hour. After half an hour, I just remove it. And they can go home. They can walk, they can drive, they can do everything. It's an OPD procedure. So twice a week, 5 or 10 sessions, depending upon the condition of the patient, how chronic the patient is. But in acute pain, even one session is more than enough, or 2 sessions.
Thank you. That's very interesting.
Pardon me?
That is very
Yes.
interesting. Thank you, ma'am.
Very interesting. And you believe me, OPD procedure, we have no admission, nothing. And they can go home, they drive and go back home also. And I've undertaken dry needling myself. I've done it on myself also. It's not painful. But before that, I usually give a kind of painkiller, 2 hours before piroxicam. And that is enough. It is very bad. Compared to the pain they're having, this pain is nothing. Because these are very fine needles.
And these needles,
yes.
Ma'am, these needles are disposable needles or
all
reusable?
Sterile disposable needles.
Ma'am, do you apply any local anesthetic jelly or any formulation?
Not required. If it is on certain areas like the face, then I apply Prilox gel. But on the back and all, when it's extensive, how much? There's no point in applying.
Yeah, right. And that's
Yeah.
one.
Even for osteoarthritis, is very useful. This lady has osteoarthritis. You have to needle the quadriceps, hamstrings, calves. They will improve with that.
Doctor, can we use this for a pediatric age group cerebral palsy cases?
Not pediatric use.
No.
Ma'am, where can we learn this needling technique?
I will ask Shripriya to share it with you. There's a place in Bombay, or if you come here, I will show you when I'm doing it. But in Bombay, there is an institute which teaches dry needling. Shripriya will share that.
Sure, ma'am. Once I get it from you, I will share it.
They are also asking for any good literatures for further reading on.
You just Google dry needling, no? You'll find the literature. I can also give some literature, no problem.
Yeah. And there's one compliment, ma'am. Wow, madam, it's an absolutely amazing session today. I have never thought of dry needling before. My heartfelt gratitude to you.
Thank you. Thank you. See, ultimately, what do you have to do? You have to relieve patients. That is the most satisfaction you get is when their pain gets reduced. Okay. And we are there for that only, no? So if you can pause that, there's nothing like that. Anyway, thank you very much for the comment.
Ma'am, one last question I'll take.
And
Is suction cupping scientific and effective for muscular pain?
no.
Okay. That's it. We have already exceeded our time. Thank you, ma'am. Thanks a lot. It was very informative and you patiently answered all the questions. Participants, if you have any more doubts, you can just
I
mail
think it was
us.
a very interactive session, and I thank the participants and Sheila and Shri Priya for organizing this.
Thank you, ma'am. Over to you, Shripriya.
Dr. Mary, it should be us who should be thanking you because you found out time in the late evening to join us. And I believe you are at Delhi and you are safe because the
Yeah,
very
a
tense.
little apprehensive, but we are safe at the moment. Yeah.
And I do hope that all the participants who have joined, especially from northern parts of the country, India, because the situation is very sensitive now. So please do take care of yourselves and your loved ones. We are definitely praying for you all. May the situation come to normal very soon.
Yeah, we can only pray that everything de-escalates and we are back to normal. It's a very uncertain situation at the moment.
Right.
Very true, ma'am. Very true. So thank you so much for joining us, ma'am. And thank you all the participants for making the session very interactive because your interactions is what makes the sessions useful for us all. So with a note that, with a promise that we'll be meeting again in the next session with yet another very important topic and yet another eminent speaker. This is Sri Priya, along with Dr. Mary Abraham and Dr. Sheila Rathod, signing off from the Tips Eco Hub. Till the time we meet again, take care everyone, stay safe, be happy. Bye-bye.
Thank you. Thank you, ma'am. Thank you, everyone.